Hello again, and thank you very much for the invitation. I love talking about regenerative medicine. I would say I have the biggest success as a pain doctor using regenerative medicine. And it's beautifully supplemented with other techniques like radiofrequency, cryo, and the intraspinal techniques. But this just creates a framework to actually help patients. So let's talk about protocols. Philip asked me, or Vincent asked me, to talk about prolotherapy protocols. But I have to say, whatever we say here, it applies for other regenerative medicine techniques, PRP, BMC as well. This is my disclosure slide. I have no financial interest in talking about regenerative medicine. I speak for Epimed, Metrum, Diros, Equip, Inomed, a couple of radio frequency and cryo companies, but nothing related to regenerative medicine. I started my education and early career in Budapest, and I spent precious 10 years in University of Washington, then 2 in British Columbia at St. Paul's Hospital and Change Pain, and now I'm back in Budapest, back home. I'm on the WIP Education Committee, and I speak for a couple of societies. So let's get to it. So here, this is a slide, is the way I see regenerative medicine feeding into tissue healing. Let's start here at what we want. We want tissue healing. And we know that it is the actual inflammatory cascade that gets us there. We cut our finger, it gets inflamed and heals. Now, what activates the inflammatory cascade? The platelet activation. Now, platelets can be activated either by PRP, beautifully, directly we get the PRP and put it in there, the platelets. But we can activate the platelets by a cell injury, a lipid leakage, which can be provoked by prolotherapy. And of course, we have the stem cells from bone marrow or adipose tissue. They can participate in activating the inflammatory cascade, but mostly they work as a conductor orchestrating the healing response. If we wonder if those stem cells actually turn into cartilage or ligaments or whatever we want, we know that they don't. A week after injecting stem cells, a week later after injecting stem cells, we have only 1% of the stem cells present. So this is the outline of my talk. We're going to talk about general protocols, and then we'll discuss protocols for lumbar spine, cervical spine, and knee. I want to refer to these 2 books. They are beautiful. I would say if you're looking for protocols, get these 2 books. This is by Joel Baumgartner, beautifully explains how to approach an area, how to get started with prolotherapy. And this is a bit more advanced by Tom Raven. I say it's much easier for DOs because they understand the biomechanics better, and they also, of course, they have the manual therapy skills. So how do we think about prolo protocols? So the key is to get the diagnosis right. You need to have a good history. You need to ask your patient, how did the pain start? Because that will give you so much information. If your patient is a soccer player, may have a hyperextension injury, or if the patient fell on the knee, you will already know what happened, right? Where do you expect the injury? Not to mention, like Tiger Woods had a car accident, you know that they're gonna have a whiplash associated disorder with the neck ligaments injured, with myofascial pain, possibly headaches or tingling in the arms, and of course the facet pain. If your patient comes with a tennis elbow, it's very good if we figure out that they play tennis, and you check if they have a good backhand technique, like you ask them to get it checked. Otherwise, they wouldn't develop a tennis elbow. Also, like you would know that these patients are so likely to have back pain because they spend so many hours bent forward and they put excess strain on their low back ligaments. And here is the hero of our age, right? We spend so much time on our phones, texting, that this is not a very ergonomic position for the head. The head is very heavy. You can expect this patient to have neck pain, loss of lordosis, pain radiating down the arm, headaches. If you know this, the history, then you can already imagine where you're going to stick your needles. But nevertheless, you confirm your diagnosis with physical exam. It is crucial to do a physical exam. For your low back patients, if you ever examine, if they have the supraspinous ligaments tender, you will be very, very surprised that yes, it is mostly super tender. We talk about the facets. We have a whole society talking about facets. But it's not enough. There is much more to it. Examine all the targets or anatomical points that you identified based on the history, if they are tender. Now you can use ultrasound and identify the tennis elbow with ultrasound exam, or you can identify the deltoid attachment problem or a partial thickness tear of the supraspinatus, no problem, with ultrasound. Now you can have an obvious change on the MRI, or you can have a less obvious change because here is the ligamentous injury, someone who lifted something heavy. Or you can use X-ray and notice that this normally doesn't show. Is it a sacrospinous ligament, or maybe it's a piriformis, but that gives an excess shadow on X-ray. Now this is also noticeable, that spinous process, and then it veers to the right and then back in line. If a vertebral body is rotated like this, then you can already expect pain in the facet joints because they are twisted compared to normal. And of course, it comes very handy if we are familiar with the referred pain patterns, like knowing that the trapezius will refer pain to the back of the head, behind the eye, right? It's very similar to many other conditions, but it will give you information where to look for trouble. So, thinking of this patient, my diagnosis is an altered posture, loss of cervical lordosis, stretched neck ligaments that leads to overworked muscle, myofascial pain, taut bends in the neck, and then of course you can have the cervicogenic headaches, potentially occipital neuralgia if the occipital nerve is entrapped, and it could also lead to tingling in various fingers as the brachial plexus may be compressed either by the musculature, or you can even have a disc bulging out and creating radicular pain. Now, staying with this topic, let's look at the cervical spine. So if you lose the support, the supraspinous and interspinous ligaments, the spinous processes will separate. There's going to be, of course, stress on the facet joints, because that's not how they like to be pulled apart. They like to maintain the healthy lordosis. There's going to be anterior pressure on the discs. The disc will bulge out and potentially push on the exiting nerve root, but certainly can push on the posterior longitudinal ligament, which is very, very highly innervated. Of course, by loss of the ligamentous structure, you can get an antero-posterior stasis. With that in mind, you can, of course, identify your targets. This is your protocol. Supraspinous ligaments, facet joints, the laminae, the deeper and the superficial cervical musculature attachment, and of course, you think of the AO and AA joint injection. It depends if the patient complains of a lot of headache, and then again thinking of the mechanism of injury. If it's a car accident, the upper joints are very commonly part of it. So these are the targets, of course, as mentioned. What's the protocol? You inject 0.5 milliliter. It could be either dextrose prolotherapy, which is 15% dextrose, or DPG, which is dextrose phenylglycerin, but really you could use PRP or stem cells. It depends what you have access to. always combine regenerative medicine with physical therapy. It's just a better outcome. This is how the patient is positioned when I do cervical prolotherapy. I use ultrasound, so I'm going to demonstrate that, but you could use fluoroscopy. Landmark guided is also taught. It just needs really good anatomy understanding to avoid trouble. So here you can see the prolotherapy of the cervical spine. This is what I do. You can see here is anterior and here is posterior. It's the same technique as you do a medial branch block almost. So this is the articular pillar, lamina, and spinous process. And the needle went on the facet joint, the lamina, and eventually it will go to the spinous process as well. Right? Now what we need to bear in mind, and it's very important, and then I go to the next level, sorry, and then I repeat the same thing again. Facet, lamina, and then spinous process. Now, what we need to bear in mind is that the spinal cord is absolutely in the trajectory of that needle. So I would say this is a super advanced procedure. Before you engage in doing prolotherapy like this or regenerative medicine like this, I'd like you to be very comfortable with every other part of the body and, of course, the anatomy of the cervical spine. Now you could inject the upper joints, the atlanto-occipital joint. You can see contrast within the AO joint. This is a bit tricky again, not a beginner procedure. This is in the AA joint. That's much easier. Possible complications are here. The vertebral artery is easily in your way. Here, not so often, but there are a couple of tricks to bear in mind. Now with that, we can go to a safer, friendlier area, the lumbar spine. Look at the studies for a second. This is for PRP. There are studies for prolotherapy as well, but I like this collection of studies here. You have a couple of prospective studies and case series and the double-blind randomized controlled trial for PRP. What you see is that they all show positive, they all show benefits of for the patient. And this is the one that was done by Lutz and his group. It's actually one study, but they followed the patient for a longer time. It started out as a double-blind RCT, but of course at the 2-year follow-up, the patients were no longer randomized, and they came out with 5 to 9-year follow-up. Now all of these showed benefit long-term. This is what they essentially did: inject in the disc, and where the disc showed leakage, like here, an obvious annular tear, and also here the previously injected contrast, you can see how it left the disc and leaked into the epidural space. They put PRP. You can do prolotherapy. My personal preference without any data is PRP within the disc. The trouble that I see with this is really, I think of the disc as these windows. And if you remember, in 1989, the Loma Prieta earthquake in San Francisco caused a lot of damage, but was identified that these windows really broke because the house's frame flexed too much. The house didn't collapse, just the windows. I think when we do disc PRP, we keep putting new windows into these houses. But the true solution is to actually build an earthquake-resistant building, with cross bracing, lots of cross braces. And these windows will be safe, still maintaining the flexibility of this building. Now, if we translate it to human medicine, then we get back to where we were with the C-spine. We need to understand and inject a functional unit. And what's the functional unit here? The supraspinous ligaments, the facet joints, the attachment of the longissimus muscles and the SI joint ligaments. The green is for the iliolumbar ligaments, and the yellow is for the thoracolumbar fascia. Again, you can inject a 0.5 milliliter of dextrose at each site, or PRP, or stem cells. The price difference is much bigger, I find, than the outcome difference. And this is a study that you could criticize for a lot of things, but the concept, I think, is pretty genius. Kirchner injected not only an individual target. He put the PRP intradiscal, in the facet, and also transforaminally. And his outcomes are way better than anything else you find in the literature, in the PRP literature. They are close to the Prolo literature, though. So what he found at 6 months, 90% of the patients showed excellent score. And I genuinely believe it. I think with this concept of tensegrity, you get those good outcomes. How you inject, again, however you can, safely. You could do landmark guided, and if you join the Hemwell Hackett course, they will teach you exactly how to do the landmarking. But you could do fluoroscopy guided. These are the facet joints. I no longer tilt my C-arm just because it's faster to go straight down and you can identify in the joints. You inject the transverse processes because that's where the iliolumbar ligament attaches, and here is spinous process injection. Again, transverse for the iliolumbar. And here is the attachment of the quadratus lumborum, and if you go medial and under the iliac crest, that's iliolumbar ligament. So because ISURA is all about ultrasound, I thought I will show you how the ultrasound guided SI prolotherapy goes. So let me start this. Pick up my pointer. So what you can see, I moved from midline to laterally. This is PSIS, the dorsum of the sacrum. This is the ultrasound probe position now. I inject to the back of the sacrum, to the junction of the PSIS and the sacrum, and just under the PSIS. And then I move my probe like this position, a bit cephalad, and I inject again to the PSIS, to the junction and the sacrum. Then I will move my probe to this lower position, and again I inject. With that, we essentially injected all the SI ligaments. There's a superficial and a deeper layer. You also injected the multifidus and semispinalis attachments. This is what I tell the patient usually. You come here and your pain and disability is, let's say, here, your VAS 6, 7. I inject you and I'll make you worse. And then nothing will change unless you're very lucky, but I don't promise. Then I inject you again and I make you hurt for 2-3 days. And then slowly it will decrease. If it's low back, I say 6 treatments. It's unusual to do more. If it's in cervical spine, smaller ligaments, 2 or 3 treatments. Same for tennis elbow, less number of treatments. Exceptions are, for instance, Ehlers-Danlos syndrome patients. They essentially cannot be helped with anything else other than this prolotherapy, and they would need more sessions. and they would be a regular customer coming back for treatment, but in between, you can get them very, very functional and happy. I cannot go without a little bit of an evidence review, at least this much, although it's not the topic of this talk. But I want you to know that there is level 1 evidence for knee OA and also level 2 available for prolotherapy. There is also level 1 and level 2 for lateral epicondylitis and low back pain. Now finally, let's look at the knee. With the knee, the concept is absolutely the same. This is a famous one, right? We even learn it at med school. The unhappy triad and the soccer player or a hockey puck hits the lateral aspect of the knee. You know what to expect. You know that there is going to be an MCL, a meniscus, and an ACL injury. It's just so logical. But we need to understand all of those mechanisms. It can be a wear and tear, and I would refer to this first Bible of prolotherapy. This is explaining how osteoarthritis arises. There is a ligament laxity, excess movement, and that's how you wear out your cartilage. So you're not only needing to fix the cartilage or cut it out with super endoscopies, you need to fix the frame. So then, remember, the Japanese building will not collapse. So here we go. Here is the knee. So what is it that we need to treat? Again, it is a functional unit. So if you look at this movie, of course we understand there is femur, here is the synovial membrane, then you have the capsule, then we must not forget about the medial patellofemoral ligament that stabilizes patella, then you mustn't miss the medial patellar retinaculum, and also the MCL. Now these structures are of course a bit looking different in real life, but the concept is important. If you only treat one of those, the overall stability will not change. It's like reinforcing one window on the earthquake building or the frame of it. You need to have the whole house reinforced. Better frames, cross braces, then the windows will not pop out again. How you do it again, truly doesn't matter. You could do landmark guided if it's an easy target. If this is patellar tendon is easier landmark guided than with any imaging. Same by the proximal tib fib ligament. You can palpate it. You don't need ultrasound and just to prolong the needle track. Of course, you need to be aware the possible risks, right? The peroneal nerve. But you can do ultrasound guided. This is a physician that's very, very convinced about regenerative medicine based on clinical experience mainly. And she is injecting her knee. What you can see here, this is PRP by the way, but prolotherapy is also equally good. What you can see here, this is her tibia, this is her femur, and you can see how the disc, the meniscus bulges out. Now that's a problem. Normal meniscus does not pop out so much. And we know that the MCL is attaching, the inner layer of the MCL is grown to the capsule and the meniscus. So she is injecting all along the meniscus, all along, to keep it in happily, and also along the MCL. What's the treatment course? Here again, I say usually for knee it's 3-4, but you can go up to 6 sessions every 2 to 6 weeks, however it's practical. Important pre-injection, tell the patients don't take any NSAIDs and don't take any corticosteroids. It's obvious reason. You want to create an inflammation, you don't want to decrease it. Post-injection, you can expect a soreness for 3-5 days. Usually my patients say it's actually not as bad as I warned them. They can move, they can stay active, but don't do high-impact sports. Don't go back to play soccer. And again, after treatment, also no NSAID, no corticosteroids. What are the relative contraindications? Again, NSAIDs. Smoking is a problem. Just like spine surgeons don't like to operate on patients who smoke because it ruins their outcomes. We know that smoking decreases blood circulation, therefore you ruin your healing response. and local and systemic use of corticosteroids are also not that great. This is a study on knee OA prolotherapy. This is beautiful. It's a systematic review and meta-analysis. A total of 228 patients. They checked WOMAC score. And overall, prolotherapy conferred a positive and significant beneficial effect in the treatment of knee OA. So as a conclusion, understanding the mechanism of injury and biomechanics is absolutely the key for picking the targets. That equals being successful with your treatment. When you treat a patient, you want to treat a biomechanical unit. You do not want to only focus on the disc or only focus on the facet because it will give you a partial response. The protocols are not that complicated. You just put the sugar water or the PRP to the right targets. And don't do NSAIDs and send the patient for a good rehab. And I'm wishing you good luck and lots of enjoyment in helping patients and not burning out, because you will truly help patients. Thank you very much for your attention, and I apologize for the extra few minutes.